Alright, great. Let's continue with tetralogy of Fallot. This is a super high yield favorite of board examiners. This is a very important slide. Focus in here, take a Netflix break after we're done. So we will start with the pathophysiology and tie in all of the bullet points in your first aid book as we go. The basic problem in this disease is that the infundibular septum here is way too anterior and superior. It is basically displaced and sitting in a spot that is not advantageous for anybody. And this sets off the compensatory mechanisms responsible for the tetrad, because the septum never descended in the correct location and ended up in a more anterior and superior position. We never closed off this interventricular foramen, and now we usually have an accompanying VSD. Now look at the shift of this infundibular septum. What did it do to our aorta and pulmonary trunk? The outflow tract of this right ventricle is basically non-existent. It is incredibly stenosed due to the anterosuperior and lateral shift of the infundibular septum. In addition, this malpositioned septum also made the aortic root sit directly above this VSD. And that is the term overriding aorta, because it literally rides over the VSD, and it communicates with both the right and left ventricle. So, the combination of the right ventricular tract outflow obstruction from the stenotic entrance to the pulmonary trunk causes right ventricular hypertrophy. It's trying to pump blood into a very small aperture. It's got to work really hard. The hypertrophy adds mass to the right ventricle, and on X-ray you will see this additional mass and dilation as a boot shape heart. It says in your book that pulmonary stenosis forces flow from right to left, but how? Well, the VSD is usually rather large, as you can see in your diagram, which means that the pressure in the right ventricle will equilibrate with the pressure in the left ventricle. So the right ventricular pressure quickly equalizes with the left ventricular pressure. It doesn't matter that the pulmonary vasculature has a low resistance if you can't get through this tiny outflow tract obstruction. It just makes more sense for blood to go through this VSD into the left ventricle and into the systemic circulation because it's lower work for the right ventricle, for that blood to move across the VSD. It does not matter that the pulmonary vasculature has a low resistance still. If you just see this little tiny opening, that's the main problem. This is the physiology of understanding a child that undergoes a TET spell and how they cure it. So first of all, what is a TET or tetralogy spell? This is where you have decreased systemic oxygen delivery, particularly to the brain, and these kids get angry and cranky because your brain does not like being low on oxygen. So what these kids do is they squat. They'll just all of a sudden squat and hit the floor, like they're in like a T-Pain video or something, like a dance move. They compress their total peripheral resistance arterioles of the systemic circulation, and therefore they make the systemic resistance jump way up. This greatly increases our afterload so that pumping out of the left ventricle is now very difficult. And this helps the right ventricle pump some blood into the lungs, because there is no longer a decreased perfusion pressure to pump into. By squatting, you increase the pressure of the systemic circulation, and now blood will try to go into the pulmonary trunk. What is the ultimate cure for this congenital heart disease? And it is surgery, where you reconnect this infundibular septum to its location, and you fix the VSD, and you increase the diameter of the outflow tract obstruction that is currently causing some of the shunting from right to left in these patients that suffer TET spells. So let's move on to the last of the early cyanotic heart defects, and this is total anomalous pulmonary venous return. Alright, let's blast through one. During development, there are lung buds, and this is from the primitive foregut, and this includes the common cardinal, the umbilico-vitelline venous systems. So the lung buds form from the primitive foregut that are supplied by the common cardinal and umbilico-vitelline venous systems. So initially, the pulmonary veins are associated with these long buds. They have nothing to do with the heart. There has to be some work done first. So the left atrium forms a little evagination, and it looks like this. This is the common pulmonary vein. It's kind of like an arm reaching out to grab somebody. So if this arm projection from the left atrium fails to grab onto the developing pulmonary venous plexus that is coming from these lung buds, if this does not occur correctly, the pulmonary veins, don't even worry about it. they stay connected to this cardinal venous system because that's where their venous plexus arises from already. Now, why is this important? So essentially, the left atrium says, hey, grab my hand, we're supposed to connect, and the lung bud with this developing pulmonary venous plexus misses. So there's no connection between the pulmonary venous plexus and the common pulmonary vein that is going to be draining into the left atrium. This is bad. Why is this important? Well, if the pulmonary veins never hook up to the left atrium, what are they going to drain into? They're going to drain into whatever structures they are already connected with. The most common you will see is that the pulmonary veins remain connected to the cardinal or the fundamental venous system that is also part of the umbilicovidulin vein structures. So guess where the developing venous system drains? The developing cardinal venous system becomes the structures that drain into the right side of the heart. This means that the pulmonary venous plexus or pulmonary veins will develop and drain into the superior vena cava and the coronary sinus, because that is where they were initially connected to. They missed out on the little arm projecting from the left atrium, and the common cardinal and umbilicovidulin venous system are part of this primary foregut, which is where our superior vena cava and coronary sinus develop into. So what am I telling you? I'm telling you that we've created a connection from the pulmonary veins directly with the right side of the heart instead of the left side. Is this bad? Yes. It is a terrible situation because there is no oxygenated blood returning to the left atrium, which means no oxygenated blood will be provided for the left ventricle to pump into the systemic circulation. We need some sort of way to allow that oxygenated blood from the lungs to enter the left, not the right, where it's currently draining, side of the heart. We usually see an associated ASD or a PDA, and this is because we have to have some way to shunt that blood that is staying away from the left atrium, and we have to be able to shunt it into the left side of the heart. So now let's go attack some other things. We did a great job with those early cyanotic lesions. Great. Let's continue with a ventricular septal defect. Remember that there is an interventricular, muscular, and membranous septum. The muscular septum develops from the ventricular myocardium, hence the name muscular. And the membranous septum originates from the endocardial cushion, which is why it's membranous. There's no muscular component to it. Most of the VSDs associated with congenital heart lesions are due to defects in the membranous septum to develop. Most of these are asymptomatic at birth, but can become a problem later on in life if they do not close on their own, which a majority do, or if the lesion is particularly large. Remember that after birth, the pulmonary vascular resistance drops exponentially and continues to do so for the first week or so of life. In addition to getting rid of the placenta that had a very low resistance, so we eliminate that rich parallel vascular circuitry, so the forward systemic pressure for the aorta will now increase exponentially. In combination with the closure of the ductus arteriosus, this all means that the left ventricle will now be working against a much higher pressure. It will be working much harder because it has to pump against a higher peripheral pressure. Due to this increase in systemic pressure from losing our ductus and losing our placenta. So large VSDs allow pressure in the right ventricle to equilibrate with pressure in the left ventricle. This means that the flow will now depend on the resistance of whatever is in front of each chamber, the right ventricle or the left ventricle. Now, which has lower resistance, the pulmonary artery or the ascending aorta? Pulmonary artery, or pulmonary trunk in this case. That is what's circled on the diagram. This means that we will create a large left to right shunt and increase pulmonary blood flow. We increase circulation and blood volume in the left side of the heart because it is going from the left side into the pulmonary circulation and back to the left side of the heart. So we pump blood from the left ventricle, across the VSD, into the pulmonary trunk, into the pulmonary vasculature, pulmonary veins, back into the left atrium, back into the left ventricle. Over time, this can cause an increase in left side heart volume to the point where we get left ventricular hypertrophy and dilatation because there's chronic volume overload of that circuit. So in addition to the increased workload that we have placed on our left ventricle, we have increased the volume and increased the shear stress within the pulmonary trunk and the vasculature. This can trigger the cascade towards pulmonary hypertension. Remember, we just discussed Eisenmenger syndrome, and we will discuss it again in a few moments when we reach Eisenmenger syndrome. For now, we will continue with exploring an atrial septal defect. So this is a sagittal view of some of the type of ASDs that we can have. This is way more information that you're required to know for your Step 1 exam, but it's great to view the different types of ASDs and be aware of them. So this image is just here to help us understand that there are different types of atrial septal defects that can occur. The most common is a defect in the septum secundum, and that is called a secundum ASD. Let's review some of the embryology quickly before we explore the pathophysiology. So, the initial septum primum grows down to divide the one-chambered atria for the first time, which is why it is named the septum primum. The septum secundum develops after or second, and it is slightly to the right of the septum primum. This occurs while a section of the septum primum is undergoing programmed degeneration, which is apoptosis. The remaining septum primum will serve as a flap to prevent any left to right flow across the newly divided atria. So to visualize that, this is our septum secundum, and our septum primum degenerated, and it now serves as a flap to prevent any flow from left to right. A septum primum defect occurs when the septum primum does not properly fuse with the endocardial cushions, and that occurs down here. And this leaves us with an abnormal communication between the right and left atria. Secundum, not primum, ASDs are usually caused by insufficient growth of the septum secundum itself. So obviously if this doesn't grow down far enough and it stops here, there is an ability for blood to flow from left to right abnormally. This small gap does not cover the space left open from the resorption of the septum primum, and there's now an abnormal communication between the left atrium and the right atrium. So next up on our list is the old ductus arteriosus. So look at this image we have here. It is important to note that the ductus arteriosus usually connects with the aortic arch distal to the branches, coming off the aortic arch. Sometimes you can have a slight overlap with the ductus connecting a little bit proximal to the last branch, which is what? The left subclavian. But most of the time this will not happen. So the ductus is placed here because while we are in utero, there's no reason for our right ventricle to pump into the pulmonary circulation. In utero, we bypass this by going this way, and then straight into the systemic circulation. We receive oxygenated blood via the umbilical vein. And it is positioned here because it can bypass the pulmonary circulation and the perfusion of the upper extremities, because it wants to go to the lower segment of the body, while oxygenated blood in the left ventricle can pump blood into the ascending aorta and supply the right innominate or right brachiocephalic, the common carotid, and the left subclavian. Again, this is the right brachiocephalic, the left common carotid, and the left subclavian. So that means that the left ventricular output is usually for perfusing the head and the upper extremities, while the right ventricle output is for perfusing the lower extremity, and that is in utero while we still have a patent ductus. So after we're born, again, we know this thing. Common theme, gotta know it, oxygen causes pulmonary vascular dilation, so that we greatly decrease the resistance of the pulmonary vasculature. The ductus closes, and we should now begin pumping normally. But what happens if it's still open is that the blood that is traveling in the ascending aorta will preferentially shunt back into the pulmonary vasculature because it is a very low resistance circuit. Does the oxygenated blood in the aorta care that it's not going to be delivering blood to the lower extremity? No. Its job is to follow physics and go with the lower resistance circuit. So there's just much less resistance in comparison to trying to keep traveling into the systemic circulation via the descending aorta. So after birth, clearly this is a problem, because now we reverse the shunt, first of all, and we're not supposed to have a patent ductus at all anyways. So basically, oxygenated blood that should be traveling into the body is now shunting from the aortic arch back into the pulmonary vasculature. How does this present clinically? Well, first of all, there is a continuous machine gun murmur, because there's always going to be blood in systole and diastole flowing across this. There's always going to be a gradient for flow into the pulmonary vasculature, because in systole, the pressure in the aorta is obviously much higher than the pulmonary vasculature pressure, and in diastole, it is also higher than the pulmonary vascular pressure. So that is what continuous throughout systole and diastole. What can we do for these kids? Well, we need to give them something to close that ductus, even though it should have closed when we removed the prostaglandin E2 producing placenta. So we know that the placenta produced prostaglandin E2 to keep it open, So maybe we should use our minds and give them something like indomethacin, which inhibits the enzyme that is responsible for the production of prostaglandin E2, and that is COX-1. Remember, COX-2 is also inhibited, but that is an inflammatory induced enzyme that is produced under inflammatory states. So excellent job here. Let's continue to discuss some more shunts. And remember, it is very dangerous to have a shunt prolonged for a period of time because we can get reversal of the shunt, and that is what we're going to discuss in a little bit more detail where we go back and talk about Eisenmenger syndrome.